Good morning, everyone, and happy Hump Day. I'm Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we want to welcome you to today's webinar entitled Overdose Prevention and Harm Reduction with James Kowalsky. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and the host by using the chat panel rather than the Q&A panel. Again, please use the chat panel for any questions. The button to open the chat panel is usually located on the upper right side of your monitor. Again, please use the chat panel to send any questions you may have as you think of them, and the presenter will address them as time permits. If you continue, our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and those options are also located in our chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording and PowerPoint, you would go to our website, www.fada.org, Resource Center Training Library. And again, I have posted the materials in a link in the chat panel if you want to go ahead and print those out before we get started. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. And again, you must be connected through audio and also be able to view it on screen. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at midnight on Monday, February the 1st. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. Please note that WebEx does monitor arrival and departure of all attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And with that being said, I would like to introduce our presenter, James Kowalsky. He's the project director for a SAMHSA-funded grant to prevent prescription drug and opioid overdose deaths at the Illinois Department of Human Services and the Division of Substance Use Prevention and Recovery. He serves as the Drug Overdose Prevention Program Coordinator and provides support to overdose education and naloxone distribution through providers throughout the state of Illinois. Since 2013, James has been providing training and technical assistance to organizations adapting their practices to incorporate harm reduction, housing first, motivational interviewing, and trauma-informed care. James and his wife, Susie, who also presents for us from time to time, provides training and consultation through their company, Practice for Progress. James is a member of the Motivational Interviewing Network of Trainers. He received a Master's of Arts degree from the School of Social Service Administration at the University of Chicago. James is committed to promoting a shift in public policy and service delivery that is characterized by acceptance and respect for people who use drugs, have a substance use disorder, or are in recovery. And James, with that being said, if you're ready to get started, I will turn it over to you. James,
Great.
can you hear?
Thanks so much, Karina, for the introduction, and I hope everyone can hear me all right. If you can't hear me, go ahead and chime in the chat box and let me know. So I do just want to say, so obviously the topic today is overdose prevention and harm reduction, so thank you so much to FADA for bringing me back, and in particular to bring me here to talk to you all about this topic. Karina mentioned the other day that over 500 people registered for this webinar, so I think it really speaks to the level of interest out there, both in the topic of overdose prevention, but also harm reduction. And I think it speaks to FADA's commitment to these topics that they are bringing me here today to talk to you all about it. Just as far as quick housekeeping note goes, if you do have questions, I will do my best to try to answer them as they come up if they're related to the specific material. For broader questions, we might hold off till the top or bottom of the hour and try to answer them at that time. And I know sometimes I just sort of miss them in the chat, so we will do our best to try to get to any questions you all have. So feel free to ask the questions when they come to you, or if you want to just wait till the top or bottom of the hour, you can ask them then. So where I did want to start, just as a quick introduction to this. So I've been studying and working in harm reduction services in different capacities for about 15 years now. And obviously I'm deeply passionate about this as an approach to helping people who use drugs. But in particular, I believe that integrating harm reduction is really fundamental to delivering substance use disorder treatment services. So for too long, harm reduction has really been thought of as something that just occurs outside of treatment, or before a person is ready for treatment. And what I really want to emphasize, what I hope you all get out of this webinar today, is the idea that harm reduction is more than just syringe service programs. Now, I will tell you, there are people out there who consider some of those more traditional harm reduction programs to be a form of treatment. Right, when someone's engaging in a syringe service program or in supervised consumption spaces, they think of that sort of being the first step in someone's process of recovery. But I'm kind of going beyond that here. I'm talking about the fact that I believe harm reduction belongs within treatment programs. So I think at the outset, it's really important to say that whether you embrace harm reduction already or not, that I think we are all coming to this work for the same reason, and that's to help people who use drugs to reduce the damage that substances cause in their lives and to support changes in their lives that will improve their health, their relationships, and their communities. If we're not using harm reduction, we're really going to be missing an opportunity to help the people who need this help the most. So with that, I do hope you'll come to this with an open mind and really look for the ways that harm reduction maybe already matches and fits with what you're doing and what else you can be doing in your work to expand and deepen your connection to harm reduction in your daily practice. So where we're going to go today is we'll kind of talk about harm reduction more broadly as a philosophy and kind of the principles behind it, but then we'll also get into kind of some of the more specific approaches to providing treatment for substance use disorders in a way that incorporates and matches that philosophy of harm reduction. And then in the second half, we're going to focus more on drug overdose in Florida and then overdose prevention as an element of harm reduction that can be integrated into your treatment programs. So I encourage you all to, do your best to stay engaged. Truly I wish I was there in person to do this, presentation for you all, because there's 5 inches of snow on the ground here in Chicago. And, I think a lot of folks know I'm originally from Florida, so we're approaching the time in the winter where I usually question my decision to live here and not in Florida at this point. But so besides that, I hope that you will do your best to stay engaged, even though we're on this electronic format. And, you have the chat box there, and then we've got a few polls sprinkled throughout the webinar today. So kind of keep an eye out for those. And so here are some of the objectives that we'll be covering today as we go through the material. So where I want to start off is with, Happy New Year. This may be hard to believe, but it is still January. It's been quite a January. A lot has gone on, it feels like. But it is still the first month of the year. And I didn't just put this slide in here so that I can wish you all a Happy New Year. I want to start here because I think New Year's resolutions can give us some insights into using harm reduction in our work. So many people use the new year as an opportunity to make resolutions, consider a change, or take steps towards making that change. And, the joke about resolutions is that people don't actually stick to them for the whole year, right? This is the time of year where gym memberships are soaring and the gyms are crowded under non-COVID times, obviously. And despite that, when people tell us about their resolutions, we tend to be really supportive, right? We want to know more about their resolution, like why they chose that, what they're hoping to get out of it. And if someone tells us something like they want to cut back on fast food this year, we don't just challenge them and say, well, why don't you give it up altogether? Or we don't just point out, well, you also eat a lot of candy. You should probably think about cutting back on that too. Or, cutting back on fast food isn't going to help if you don't start exercising. You should kind of add that to your list, right? We don't try to push people beyond the goals that they are identifying for themselves. We accept and support those goals that the people set for themselves. And if you're like most people, you've probably had this very normal experience of setting a resolution for yourself at the beginning of the year and falling short of your goal. Maybe you just weren't able to sustain it for the whole year, or you didn't quite hit the goal exactly the way that you planned, or you kind of had to make some adjustments and corrections along the way. But either way, resolutions really show us how hard making changes can be. It's not an easy process. And just because January 1st shows up on the calendar, it doesn't mean that we're ready and able to make some big change in our life, right? Time markers or some official event doesn't mean, okay, now I'm ready to make a change. And I think the danger with this kind of way of thinking about resolutions as, something that we're not going to stick to, or, what's the point anyway, is some people end up skipping resolutions altogether, or they avoid thinking about them or thinking about anything they could do to change or make things better in the next year. Maybe they're just setting the bar too high for themselves, or they don't want to commit to something in the long term. They think, well, if I'm only going to do it for a month or 2 months or 6 months, well, what's the point? I don't know if I could do this forever, so why bother trying? Or maybe they just think they're going to fail. And I think when it comes to resolutions especially, we have more of this mentality that it is okay to fail, right? That same person who said, well, I'm going to cut back on fast food, when we talk to them in a few months and they say, I did pretty good for a month, I really cut back, I was down to, once every few weeks, I would still go. And then I kind of had a little drop off and it didn't really go as well for a while. I think I'm going to try to go back to it. But we don't condemn them. We don't throw it back in their face. This kind of falls into, we've heard maybe the expression, don't let the perfect be the enemy of the good, right? Making the attempt, I think, is commendable. So when we come up short on our resolutions, a lot of times we treat it like something that we need to hide, or we just laugh it off. Oh, that wasn't really that committed to that. That wasn't that big a deal. I was just kind of trying something out. But trying takes a lot of work, right? And that in itself should be commended. And beyond that, when we test out a change, it's also a really important learning opportunity, right? What did I like about making this change? What was manageable or unmanageable, right? Take what you like and leave the rest, right? So what parts of this change really worked well for me, and what parts don't really fit with where I'm at right now. So when we think about the resolutions that actually are very successful, the ones that result in a lasting change or some positive improvement in our lives, most likely those are not the ones that were decided at the spur of the moment, right? The ball dropped and we're like, I have a good idea. I'll change this big thing about my life. Instead, they're the ones that people spent a lot of time thinking about, right? People did some serious planning and preparation before December 31st, right? Before switching over and making that resolution. And all that contemplating and planning and preparing, all of that likely happened while they were still engaged in the behavior that they were hoping to change. So I think that's all really important to kind of keep in mind as we think about how we approach people and their substance use. That even when people are maybe engaged in a behavior they hope to change, that there is work that they can be doing that moves them towards an ultimate goal or a resolution. So Happy New Year, and maybe this next year, may we all kind of bring this open-minded attitude about resolutions into the next year, one where we have humility and empathy and curiosity, and that we kind of infuse that into our work in substance use treatment. So I want to come here. This is a very broad definition of harm reduction, but I think is helpful to give us an overview and starting point. So you see here, harm reduction represents both an attitude and a set of pragmatic and compassionate approaches designed to reduce the harm stemming from high-risk behaviors and improve the quality of life for affected individuals and their communities. Unlike the disease and moral models of substance use, harm reduction focuses less on individually located psychopathology and morality and more on the larger social context for substance use. It allows for complexity and nuance in our understanding of human behavior. It empowers affected individuals to take control of their behavior on their terms. So I think in here, nothing too controversial, hopefully. This way of thinking about harm reduction really developed out of the experiences of people who use drugs, helping other people who use drugs. But it goes beyond just substance use, right? When you see something like reducing the harm stemming from high-risk behaviors, we really can broaden out harm reduction to apply to a lot of different things. But you see, there's both kind of the actual strategies, the approaches and services that we offer in harm reduction, but there's also this broader attitude. And so we'll spend some time talking about what that means to have an attitude of harm reduction or philosophy of harm reduction in your service delivery. And I think something that many people in substance use treatment acknowledge and I think would embrace is this idea that the social context, the setting around someone really matters when we talk about their substance use. We know that there are factors in someone's lives, beyond just really internal factors that make a difference in people's relationship to drugs. And this idea of empowerment is something that probably all of us already are trying to help people promote and pursue in their lives and in their recovery process. So we're here at our first poll. So I'll give Karina a second to pull this up. So you should see the poll question over there on the side. And I want you to take a second before answering this. So I'll read out the question and some of the responses. And obviously polls are completely anonymous here. I don't know who's saying what. So take a minute and do try to sit with the question for a second. But when I tell you the people who, how true is the following statement? The people who attend my substance use treatment program know what is best for themselves. Do you think that's always true, usually true, sometimes true, rarely true, or never true? And again, just take a second to sort of think about the people who you serve, who you are engaging with, what kind of conversations you're having with them, and where do we fall on this on this spectrum? Do we believe that people know what's best for themselves? I'll give you a couple more seconds to respond into the poll. And then Karina, I think if you can go ahead and close that out. Looks like the poll is ending. So where we fell in terms of the results is the vast majority of people think that this is sometimes true. I think only a handful of people responded that this is either always true or never true. And most people kind of fall into this middle range, right? About the same number of people think this is usually true or rarely true, but the vast majority of people think this is sometimes true. And this is a really fundamental element and question that we need to ask ourselves when we're working with somebody in our substance use treatment program. So when we think about things like motivational interviewing and promoting people's autonomy, it's really essential that we essentially allow ourselves to believe that someone knows what is best for themselves. And that kind of brings us to this next slide. Generally, we would say that we can't know someone better than they know themselves. And yet, when it comes to substance use treatment, we're sort of inclined to believe that because this person ended up in this situation, because they have this harmful relationship with drugs and alcohol, or maybe they ended up in the criminal legal system, they've been mandated or referred to treatment, whatever it might be that sort of brought them to our substance use treatment program, it really leads us to believe that this person doesn't know what's best for themselves. Maybe they would have made different choices if they knew what's best for themselves. And it inclines us to take away some of a person's autonomy, some of our desire to let people guide the process. And I think those are things that we value in substance use treatment, right? We know that it is important for people to take ownership of their lives, for people to feel like they're in control and to help them build back that sense of control in their recovery process, to make decisions that they identify for themselves, that they think of as best for themselves. And yet, this questioning about, well, do they really know what's best for themselves can lead us into more, directive approaches, less sort of grabbing the steering wheel for someone essentially and trying to show them where to go instead of being open to letting them lead and guide the process. And so I think that's something that'll kind of come up and be in tension. And I think part of what underlies that desire to take over for people and to not just let them guide the process and work through things on their own and at their own pace is partially this question of, do you know what's best for yourselves? But I think there's something more than that going on as well. And so when we think about things like, our attitudes or our feelings about getting high, our beliefs about people who use drugs, I think those are really important things to sit with and unpack when we're doing this kind of work. So we all come to this work with our own experiences, with our own ideas about drugs, alcohol, what it means to use them, why people do them. Maybe we have personal experiences. Certainly, we're all exposed to a lot of different ideas about substance use through the media and society and culture. And by and large, a lot of the messages that we get about people who use drugs and alcohol are not particularly positive reflections of who they are or what they are like. So, if you can go ahead, throw into the chat maybe some of the things, maybe some of the negative attitudes that you might have about people who use drugs, or maybe things that you think our culture sort of says about people who use drugs. Go ahead and use the chat to throw out some suggestions of things that some of the negative attitudes or beliefs that we hold about people who use drugs or people who choose to get high.
So, James, some people are sending it to the host only, so I'll read some of those. They should just choose to stop. They have low self-esteem. Culture says that people who use drugs is that they are weak or it's a choice. Some may say that substance abuse users are weak and lazy. Addicts lie, steal, or become dangerous. Trauma, lack of self-control, liars. My religious beliefs causes me to believe it's purely sin manifesting itself. They're irresponsible and can't take care of themselves or children. Culture says they're selfish, self-absorbed, looked down on, traumatized. How do you know an addict is lying is when his lips are moving. So it looks like a lot of the same stuff.
Mm-hmm.
They're never going to change. They are self-pitying and not fit for the work.
Yeah. So I'm gonna have you all hold off. I think a really good example, and probably as everyone was hearing that list, you weren't hearing things that seemed out of the blue or shocking to you, right? When you hear people say things like, "Oh, people who use drugs are, weak and selfish and lazy or irresponsible," those are things that match with sort of the cultural perceptions that you've been given. And we, as much as we talk about how we want to destigmatize substance use, we want people to feel like human beings. We want them to recognize their own worth. We can't separate ourselves from the fact that we come from a culture that has sort of ingrained a lot of these really negative ideas about people who use drugs into us. And those negative ideas that we hold, they can pop up in little ways, and they can cause us to violate our own principles about how we're going to work with someone. I mean, I think someone in their example said addicts may lie, and I think that's actually really generous, because I think the expression that I've certainly heard from people, both who are in recovery and from people who are kind of outside of being directly affected necessarily, is addicts are liars, right? Not addicts may lie, addicts are liars. And that idea is not unheard of, I don't think. But how does something like that influence our treatment of people, right? If we're taught to treat people as liars inherently, right? And we would never say this about really anything else, such a blanket statement. Certainly not when we talk about other health conditions. Like, no one would ever say diabetics are liars. No one would say cancer patients are liars. No one would say, people with bipolar disorder are liars as a blanket statement. And so those kinds of really insidious comments and thoughts about people who use drugs have made their way into our culture, made their way into our thinking. And I think we need to be really conscious about that and aware of that. And we don't often get a lot of opportunity to sit back and think more generally, what do I believe or think about drug use itself, about the people who use drugs, about why they do it. And I think probably some of what I saw in the comments also starts to indicate a little bit of more of the nuanced perspective that you all working in substance use treatment do have about people who use drugs. So a couple people mentioned trauma, or understanding that, thoughts about people who use drugs might be that they're traumatized. I think that if it is present in our culture, I think it is in some ways, is a pretty new development in the way that we think about people who use drugs, that people who use drugs in harmful ways are more likely to be traumatized, is probably something that's a little bit more prevalent and something that we're more aware of in the substance use treatment field. But again, that if we approach people with this image of a drug user in mind, then it's going to be really hard to listen with empathy, to believe and trust in the things that they're saying, right? That this negative attitude that really we've been kind of told to have about people who use drugs can cause us to treat people with skepticism, to be suspicious of them, to assume that they're trying to manipulate us when maybe they're just sharing what their truth is in that moment. And so I think, whether it's getting high or, I think even just using drugs in general, we start to see, again, we talk about things like people using methadone and buprenorphine to treat an opioid use disorder. Those same questions, not so much about, I think partially about getting high, but more just about using drugs in general, creep into our minds. And in general, I think people are interested in avoiding the use of certain drugs, even if it's a medication, even if it's prescribed by a doctor, right? So we've probably all either ourselves or known someone who got a medication prescribed by a doctor and just didn't want to take it because for whatever reason, right? There's lots of reasons why people might not want to take a medication. And I think some of that, again, is connected to our idea about what it means to be a person who uses any kind of drug. At the same time, I think it's also important to recognize, just like we bring our attitudes about people who use drugs into the room with us, the people who come to our programs also have expectations about what they're going to encounter, and they have internal stigma. And a lot of the time, those beliefs about those ideas about what they're going to encounter when they come into a treatment program, they're not unjustified. There is a long history in substance use treatment of some pretty abusive and threatening and demeaning practices, things like literally sitting people in the center of a circle and having people tell them how worthless and terrible and awful they are for the choices that they've made, for the harm that they've caused to other people. Having people sit in diapers and dunce caps, these things that, if you didn't know that they had happened in the past, would be hard to believe that this was really, considered the forefront of the substance use treatment field. And I think more and more now they're looked back on the way that, in the mental health field, things like lobotomies are looked at, which is like, I can't believe that was our way of helping people, was to just make them feel really awful. And what we know is even without, these kind of demeaning practices, people still come in feeling really terrible about themselves. So I think this image here in the middle kind of illustrates just how many negative feelings people come into substance use treatment feeling about themselves. And part of that comes from the culture and the society, right? The same way that, a lot of people we treat come from the same communities and the same cultures that we come from. So they've heard those terrible messages about people who use drugs as well, and probably some of that has worked their way into their thinking about themselves. But they've probably also done things that they're not proud of, things that they're unhappy with. And especially the folks who are seeking out treatment, they probably want to avoid some of those unpleasant, uncomfortable choices and problems that they have experienced in the future. And I think that's part of where we come in. Is it's really hard to help people see themselves as worthy and valuable and capable when they come in with this like really heavy stigmatized baggage about who they are and what they're capable of, right? Not only is it important to want to make a change, it is important to believe that you can make a change. And if you have these ideas about yourself that you're fundamentally broken and incapable, it's going to be really hard, no matter how important it is, it's going to be really hard to actually make the changes that you identify for yourself. So after unpacking a little bit about kind of our expectations and attitudes and other people's expectations, I think here we're ready to get into some of the foundational elements of harm reduction. So these are also called the principles of harm reduction. But as a starting point, respecting the rights of people who use drugs. And I think that applies to a lot of different places, but, in terms of, when we think about the idea of human rights, people having access to, services and resources that meet their basic needs, having adequate food, housing, shelter, and social services are basic human rights. And that they shouldn't be denied to someone just because they are a person who uses drugs. Understanding that drug use exists on a spectrum and that there are safer ways to use. So something that, it is not all or nothing thinking here. There are more and less risky ways to use a drug, any drug, and that is hard to believe or hard to stomach maybe in some ways, but it is always true that, when you're using a substance, there are things you can do to keep yourself safer, whether that's, not operating heavy machinery or making sure you're using in a safe place, whatever it might be. I think of a lot of the harm reduction principles that we have around alcohol, right? When you're out at a bar and you call a cab or an Uber or a Lyft to get home, that is a safer way of using than choosing to drink and drive. When you are using alcohol and you eat something before you start drinking, when you drink water in between drinks of alcohol, none of that means that you're actually using any less of the substance even, but you're still using in a safer way. Establishes quality of life as the criteria for successful interventions. So as opposed to, I think, more traditional approaches, which strictly put the emphasis on abstaining from all mind-altering substances or abstaining from, even the drug of choice, the goal of improving quality of life is really important in harm reduction, and you see it kind of throughout. So beyond just making changes to a person's substance use, making the change to your substance use is only important insofar as it improves your quality of life, right? So, if somebody was coming into a treatment program and they were completely abstaining from substances, but they were still miserable, they were still disconnected and isolated, we wouldn't think, oh, job well done. I'm all set, right? There's still work to be done there. And I think harm reduction just puts that work first and kind of foremost is how do we help someone improve their quality of life, whatever path that requires or takes. Providing non-judgmental, non-coercive delivery of resources and services. So I think in particular, that's where you sort of see things like substance use treatment coming into play is what services are you providing people in a non-judgmental and non-coercive way. And again, people are expecting when they come into our treatment programs or service providers, they're expecting to be judged. They're expecting to be coerced and shamed. And so it really does take vigilance on our part to make sure that this isn't that being judged isn't someone's experience, right? When someone's engaging with you, they're going to be noticing the things you say, the ways you engage with them, the faces you make, the little expressions, and they're working from the assumption that you're going to judge them at some point. So we really have to constantly be attentive to this to impress upon people that we do not judge them or we do not want to coerce them into making certain choices. And I think that can also be really hard when there is part of us that doubts whether this person knows what's best for themselves. And maybe to sort of accept that even if they don't necessarily know what is best for themselves in this situation or they don't see it right now, that they have a right to sort of explore the path that they think is best for themselves as a starting point. It does not ignore the dangers of drug use or other risky behaviors. I think this is really important, especially for people who are skeptical of harm reduction, because I think sometimes when we talk about harm reduction, people think that we're just sort of saying, well, anything goes. Just go crazy, go wild, do whatever you want, and we just sort of take this hands-off approach to people. When in fact, harm reduction is really about educating people on both sides of the spectrum, right? That there are dangers and harms and risks associated with the substance use you're engaged in or the risky behavior that you're engaged in. And I also want you to be educated and informed about the fact that there are also safer ways to do what you're doing. And that if we provide people that full education and that full spectrum, that it really does put them in control and empowers them to make healthier choices in their lives for themselves, right? Not because we're imposing it upon them, but because they have all the facts and information in front of them and can try to make a choice from there. Here you see kind of the recognition. So the next point recognizes the impact of social inequalities on drug-related harm. This is, again, where we get beyond just, you know, are you a good or bad person and that's why you use drugs? Do you have a disease and that's why you use drugs? But recognizing that social inequalities make a big difference in terms of people's way and pattern of substance use and the relationship that they develop with drugs. So I wouldn't shock you all if I told you that, you know, someone who has experienced trauma and poverty and lives in a dangerous neighborhood with limited educational and employment opportunities, that person is at a higher risk, right? We talk about risk and protective factors, that person is a higher risk for a harmful relationship with drugs. Right? We know these social inequalities make a difference, and I think harm reduction is very aware of that as well. And then ensuring that people who use drugs or have a history of drug use have a voice in the programs and policies intended to serve them. So I think here we're really talking about going beyond the suggestion box. Although suggestion boxes are good, I will say I've definitely been in programs where the suggestion box actually yielded some really good suggestions, but going beyond this. And so that looks like, you know, providing people with representation on a board, giving people more opportunities to sort of give feedback and influence the type of services that they are going to be receiving when they're in a treatment program. So here's some broad stroke strategies for integrating harm reduction into your substance use treatment program. So you can actually incorporate what's called harm reduction psychotherapy, and I'll share a little bit more about that, into both your approach and then into substance use treatment programs. Next, building awareness of harm reduction interventions to reduce risks associated with substance use. So that can look like, you know, what psychoeducation are you providing? What types of resources and services when you're talking to people about their goals, when you're talking in groups, what sort of things do you kind of lift up and honor and validate versus the things that you try to discourage or push away? And then the last one here, develop relationships with harm reduction community providers or harm reduction providers in your community. So again, you know, this in some ways I think can be sort of a cyclical relationship, is that if you are connected to the program that is a syringe service program, when they're engaging people who are using drugs, first off, they're keeping your potential or future clients a lot safer and healthier, which is a great service. But then also, you know, they're going to need someone to refer to when the person who comes to the syringe service program eventually is like, hey, I'm, you know, sick and tired of this and I want to give it up. I want to give treatment a shot, or I want to try taking medication. Who can you connect me to, right? And so I think harm reduction providers both can be a really important referral source, but also, you know, we want people to be aware of the harm reduction services in their community in case they should end up needing them or in case they know people who need them. And so I think that brings us really nicely into this idea of who does harm reduction help. And you can kind of see here, it really is a broad spectrum. So it definitely helps the people who may want treatment someday. Like I said, that person who is engaging in the harm reduction syringe service program, who may want to do treatment someday, is kept safer and healthier and better able to engage in treatment by both the services they receive, but also by the practice of engaging in services, right? That people, when they go to a harm reduction service program, they're getting in the habit of building a relationship, of trusting someone, of working with someone who cares about them and familiarizing themselves with, hey, there are people out here who want to help. The people who are not ready to stop using, the people who say they're going to return to use, right? If you've had some clients or people in your program at some point who said, this is all well and good, but as soon as I'm done with this probation or whatever it might be, I'm going back to using. And so helping that person and being able to have a conversation with them to say, that's okay, and what do you think you'll do to keep yourself safer in the future or to keep yourself out of this situation again in the future? It also can be helpful to the people who are already engaged in treatment and then the people in their community and social networks. right? That what people learn in treatment, they can actually bring back to their own community and social networks. And then the family and loved ones of people who use drugs, that they're impacted too by what happens to the person who you're seeing in your program, to the person who is engaged in drug use. And that as much as we can reduce the harm and damage done to that individual's life, that feeds out into the other people in their networks and in their lives as well. And I think when we think about, I think a helpful thing here to just mention real quick is when we think about the stages of change, so whether someone's in pre-contemplation, contemplation, preparation, or action, right, everything leading up to maintenance, basically, active substance use, by definition, is really expected in all of those stages, right? We would expect someone to be using to some degree in all of those stages. And so that's why I think it's really important that talking about harm reduction strategies or being able to provide referrals to harm reduction organizations conveys to the people who we're working with that no matter where you are in the change process, what we care about most is that you're alive and healthy and not putting all of the emphasis just on are you continuing to use or not. So when we talk about practicing harm reduction, this is where you see sort of some of those principles and philosophy coming to life. So a low threshold to access services. We want to try to get people in the door, first things first. So even if they don't come in, essentially in the action stage, right, completely ready to stop using or already experimenting with abstinence and just need a little bit of a boost with it, sometimes we work with those clients, but those aren't the people that harm reduction is going to bring in. Harm reduction is going to bring in the people who might just be in pre-contemplation or contemplation right now. Integrating a biopsychosocial approach to substance use, so not just taking into account sort of the physical condition of the person, but also their mental health and the social circumstances around them. Treating people with respect and avoiding shaming, right? That we know that at the end of the day, punishment doesn't work. When we try to punish people into making changes, all we do is, we teach them how to avoid getting punished. We're not teaching them anything about how to make positive changes in their life. Does not use predetermined goals or interventions. So it doesn't say, now that you're in our program, here are the things you need to do, and instead expands the menu of options, right? Let's explore what goals you might have for yourself. Along those lines, celebrates any positive change. So as people take any steps towards, towards making steps on their goal or making progress on a goal, whatever incremental changes or steps they're taking, we want to celebrate and acknowledge those and honor those. And then empowering and encourage people to take ownership of their lives. I think any program that is practicing harm reduction, you would see these elements present in them. And so we'll talk about, I think, how this can be present in a treatment program, but also in your direct engagement with people in treatment programs. I think this is a helpful quote here from someone who was treated by Alan Marlatt, who's considered one of the founders of the harm reduction psychotherapy practice. But if abstinence was required as a precondition for me to get any therapy at the beginning, I would never have started treatment of any kind. So again, getting us, I don't know if you can see this slide. It's not on the screen. There it goes, sorry. So there's the quote, and you can see it now. If abstinence was required as a precondition for me to get any therapy at the beginning, I would never have started treatment of any kind. And so there, again, putting us in this space where we can sort of consider, who are we missing out on? If we say to people up front, you need to stop using all substances altogether at the very beginning when they walk in, or that needs to be your ultimate goal, we're going to lose a lot of people who can definitely make some positive changes in their life and who may ultimately decide that that is what they're interested in. So here we get into harm reduction psychotherapy. I would say actually harm reduction psychotherapy follows a pretty similar development course to motivational interviewing. So, obviously I think people are more familiar with motivational interviewing than harm reduction psychotherapy, but both have been being used and developed for around the same amount of time, maybe motivational interviewing slightly longer. But But when we talk about harm reduction psychotherapy, where it comes from is there were people who were doing substance use counseling, providing people treatment services, and much like Miller and Rolnick, it was Tatarsky and Kellogg and Denning and Little and Marlatt and Collins who were looking around and saying, this approach of being directive and combative, this doesn't work for people. This doesn't actually help them in the way that we are wanting to do. And so these principles really developed, and these principles of harm reduction psychotherapy developed out of the harm reduction service model, and were sort of adapted into what it means to provide counseling on this individual level. So first, do no harm. I think a really straightforward example of this is when a recurrence of use happens, when somebody returns to using, that we don't kick them out of treatment, right? We know that things that are good for people who have a substance use disorder are to be connected, to not be isolated, to have a network of people who care about them and who want to help them. And if we kick someone out just because they use drugs, then we're essentially doing harm to them by closing the door on them, by pushing them away, when all they're doing is exhibiting a symptom of a substance use disorder, right? Using, in spite of the consequences you've experienced already, is a symptom of that substance use disorder. So first, do no harm. Drug set and setting and understanding people's relationship with drugs. So this, again, is more of the biopsychosocial approach, taking into consideration not only the substances that people are using and their mental and emotional state, but also the setting around them and how that influences their relationship with drugs. Understanding that drug use is initially adaptive. So understanding that people wouldn't use drugs or kind of learn to use drugs as a coping mechanism if it didn't have some type of positive impact in their life, either currently or in the past. And so we can't just skip over that. We really need to understand that and infuse that into the services that we're providing. So, I was sitting in on a session with a counselor one time, and someone said something like, I use alcohol because I feel depressed and it helps me like not feel as depressed. And the counselor was like, well, alcohol is a depressant, so it's really only going to make you more depressed. And so that's not really going to be helpful for managing your depression. The counselor was coming from a place of wanting to help this person not feel as depressed. And yet what ended up happening was they sort of undermined the fact that this person is using alcohol as a means of coping and managing their depression. And that's sort of that idea that we need to understand drug use is adaptive, and the more we can understand and help people understand, unpack really how their drug use has been beneficial to them, or what they are getting out of it, or what role it's playing in their life, the more we'll be able to help them work through maybe other options that can provide that, or just sort of understanding more where they're coming from. So active drug users can and do participate in treatment. I think that's a pretty fundamental thing to be able to accept, that even as people continue to use, that they can make these positive changes in their lives. Harm reduction embraces individualized and strengths-based care, right? So not just preset, again, this is like not the predetermined goals, but really letting people sort of name their own goals and come up with plans that are really based on the individual and what strengths they bring and what goals they identify. Any reduction in harm is a step in the right direction. Again, that any positive change mentality in the treatment process, that we don't withhold, our ability to celebrate and validate what people are doing until they make the ultimate goal or meet their ultimate benchmark. But that every step along the process is worth holding up and showing the person and saying like, wow, you're really putting a lot of effort in, you're making progress, I can see it here. And developing a collaborative therapeutic relationship. I would say this is fundamental in harm reduction psychotherapy, obviously, but really in almost any current method of providing treatment is we know that building a therapeutic relationship is really essential. And then you see here, destigmatizing people who use drugs. What can we do to sort of break down the stigma that we ourselves have, but also that people bring in about themselves and that I think exists in the larger society. Here, next I'm going to talk about administrative harm reduction. So I am an administrative social worker these days. I don't do as much, I don't do any clinical work at this point, but I want to say, a lot of what we talk about when it comes to harm reduction sound like very individual clinical choices, but all of these clinical choices are guided by administrative decision making, or they can be at least. You who are counselors on the call, you can make choices. You have a lot of freedom in your individual sessions, in your groups, in the material you bring. You do have the freedom to incorporate harm reduction in your services. And I see there's actually a question about this, so we'll kind of come to that in a second as well. But also, for the administrators on the call, if you think that harm reduction has value, if you think that harm reduction can help the people who are in your programs, you need to be explicit about it. You can't just leave staff to assume what the goals are. So I was facilitating a consultation group. We were talking specifically about motivational interviewing and the idea of autonomy and how do we help people build a sense of autonomy and control in their lives. And the counselor was saying, I feel so much pressure and time is so limited with the people who I work with, and I need to get them to stop using. And the supervisor was in the group as well, and he said to the counselor, why do you think that? Nowhere in our policies or rules does it say our goal is to get people to stop using drugs. And true enough, it's not in any of their materials, but it is something that we just sort of internally believe when we're working with someone is my goal needs to be to get them to stop using drugs. And I think that's especially true when someone's, for instance, mandated or, under some form of probation or supervision. And, the supervisor in that moment said, our job isn't to get people to stop using drugs. Our job is to help people identify goals for themselves and to help them pursue those goals and to help them understand, what it is about those goals that are important or why it's not working out. And again, this idea that, that counselor and supervisor were making explicit something that I think was just sort of assumed on the part of the supervisor. But if we're not saying those things out loud, we can't know that's actually, or, staff can't know that that's actually what is available or an option for them. So, here are some of the different ways that we might incorporate administrative harm reduction into, or infuse harm reduction into our programs as administrators. Things like hiring and onboarding. So you may not say in the interview, what do you know about harm reduction, or how would you use harm reduction in working with someone? But you can ask situational questions. When you're working with someone who says their goal is to stop using cocaine, but they don't want to change their alcohol use, how would you talk to that person? What sort of things would you work on with that person? And you set up those situational examples to see, does this person maybe have elements of harm reduction, even if they wouldn't name it as such right now? Accepting non-traditional goals or interventions. When I say that, I mean a few things. One is, non-abstinence goals, for instance. If someone's goal isn't to stop using, but is to maybe use in less harmful ways, or maybe it's, using slightly less, or maybe their goal isn't related to their substance use at all. And sometimes these get called recovery capital goals, but their goal is related to wanting to get a job, wanting to reconnect with family members, wanting to improve their health. And we may know that if they were completely abstinent, that might make those other goals more achievable or more likely, but that doesn't mean we need to put that at the forefront of the conversation. And there can be an urge to sort of jump ahead. But when we write out something like a treatment plan and we put goals on there that aren't just about the person's substance use, but are about the goals that they're identifying for themselves, as supervisors, if you're checking treatment plans or working with people on them, you want to let them know that that is valid and totally accepted, and really encouraged, I would say. I think kind of along the lines of, non-traditional interventions, I think that goes the other way, which is something like, urinalysis or urine screenings, drug testing. Those are something that I think are considered pretty traditional interventions. And for some of us, maybe we don't even think about it as being part of treatment because it's just so taken for granted at this point. In general, harm reduction psychotherapy doesn't involve the use of drug testing. It just would not require that, certainly not mandatory drug testing. I know of some programs that include harm reduction that offer it upon request for people who want to hold themselves accountable, or they want to do a test to make sure before they go in for a job, or they want to share the results with a family member. But they offer it upon request but not require it. And we know people are more open about their use when we build a strong therapeutic alliance with them. And that therapeutic alliance, I think, is really challenging to build when, before you ever sit down to talk to a person, you're standing in a room with them, watching them pee into a cup. And that does make it really challenging. So it may be risky, but it's also risky that, it's also a risk that people might leave treatment because they don't feel like their counselors trust them. I know so many people who are in treatment have probably had arguments and fights and uncomfortable situations related to drug testing and urinalysis. And that's just sort of one example of the practices that are present in administrative harm reduction. I'm realizing we're at the hour already, so I'm going to try to get through this slide, and then we'll take our break here. A couple other quick points, though. Responding, when people return to use, are we mandating them to disclose that in groups or providing ultimatums about what path they need to take because of their return to use? Are we willing to serve people at different stages of change and to recognize that is very challenging? It is very hard when you have someone in a group who is, on the path, has already been abstinent from substances for a while, and someone who is still chipping and using every once in a while, or someone who's not ready to stop using. Overall, I will say, when we're talking about introducing harm reduction into a treatment program, we should accept that, the people who we might engage into treatment might be less motivated, might be more likely to disengage from services, but at the same time, those are also the people who need help the most. And so as an administrator, you need to prepare for the fact that there may be this drop-off in retention rates. And while that outcome may suffer, what else are we bringing in? Right? We're engaging people who are at higher risk, people who need more help. And so I think, broadly speaking, I think of the words, an old executive director of mine used to say. He used to say, harm reduction is the harder path. Right? So make no mistakes about it. It is not easier to use harm reduction in your substance use treatment program. It's easier to say no to people, to close the door to people, to refuse them services because they're continuing to use or they don't have, complete abstinence as their top goal. The harder thing to do is to stay engaged with people and to continue to work with them. And what I will say is, for those of you who work in the field, you probably didn't come into this field because you wanted to work with easy clients, right? The people who work in other places, they don't necessarily have the skills and the patience and the compassion that is needed to work with a really challenging population. But people come to this field because they are passionate about helping people who use drugs, and they're very often driven by a mission to do more for people who regularly get turned away from care and support. And that turning away, I think, happens in a number of different ways. That's why I think, again, just a couple other points on here, partnerships are so important because if we don't know who we're sending someone to, we run the risk of giving them a connection to someone who also hold these really negative attitudes about people who use drugs and are likely to then turn them away from services. Like a therapist or a psychiatrist who isn't going to work with someone until they're completely abstinent from drug use is not a helpful referral if we're trying to incorporate harm reduction practices. And similarly, our discharge policy, right, that, if somebody maybe isn't assessed for the appropriate level of care that we offer any longer, and we offer them the ultimatum of either you go to the higher level of care or we stop serving you here, or, you used again, or you missed 3 groups, I'm discharging you now. All of these really harsh lines that we set, we need to kind of think about the reciprocal consequences and what message does it send to people. Are we turning away people who are making a good faith attempt to try to make positive changes in their life? And what could we do instead to help stay connected with them? So I'm going to leave it here. We'll take a 5-minute break. It's 10:05, and when we come back, I'll see if there are any questions, and we will talk about those when we get back.
So we want to welcome everyone back from break. And James, if you have time, there are a few questions on the board. Just let me know if you're ready for them.
Yeah, I can kind of just address a couple of these while people are getting resituated. So one was just a question of examples of treatment programs that do kind of programmatic harm reduction. And I know of one program here in Chicago that, offers substance use treatment. They do not do residential, but they do intensive outpatient and outpatient, and they specifically incorporate harm reduction into their approach to working with people who use drugs. They also integrate things like, motivational interviewing, mindfulness-based sobriety, and so they kind of intertwine those different practices together. So thresholds, and if you want to reach out to me, I'd be happy to put you in touch with someone from their program who might be able to share some materials. The other two questions we had, so one is specifically integrating harm reduction into substance use treatment settings that are residential. And then another question about enabling. So feeling like this person who asked the question is a case manager who feels like they provide financial assistance to people who are in need, and then some of the folks end up spending the money on drugs or in order to get a bill paid. And so what are some of the thoughts on that situation? So a couple things here. So, and I think these two things are related. One, in terms of, just working in a residential treatment setting, obviously a lot of the times those treatment programs that are inpatient are going to have a rule that, a person cannot use substances while they're there, or that if they do, they will be discharged. And so I think, those policies, for one, I think are really a challenge. And maybe if you're a counselor in that program, you don't necessarily have any control over those types of decisions, although you might be able to advocate for someone. So if someone does end up using while they're in an inpatient setting or in some type of residential setting, you might advocate for them. But in particular, I think, just the materials that we bring to groups can influence and promote kind of a harm reduction approach. So exploring sort of this more nuanced approach to substance use, the idea of drug set and setting, and introducing these concepts, talking about substance use beyond just the disease model, and not just saying you have this, chronic relapsing brain disease and you'll always have it, but to try to bring different models of talking about substance use that might appeal or fit better with people's own personal experiences. We know that people, there are definitely people who do embrace saying, like, I have a disease, I am addicted, and then there are others who that just doesn't work for. And so I think presenting different models and different ways of thinking about substance use treatment to sort of complicate the conversation is one way of doing that. I think also the psychoeducation we provide, and I'll talk more about that, as we get into the overdose prevention material, but, as an example, talking about overdose prevention strategies is a way of incorporating harm reduction into a residential setting. So we'll get more kind of into the detail there. Then I think broadly the other thing, and we talked about this a little bit in the first half, is the idea of goal setting. And what goals do we work on with people? What goals do we allow people to name for themselves? How do we transpose what they tell us into a treatment plan? And, if you've worked in substance use treatment for a while, you've almost certainly met people who have come to the conclusion that there is no level of moderation that is reasonable or manageable for themselves. That the only safe thing that they can do is to completely abstain from all drugs. And that is definitely a reality for some people, and kind of a conclusion they come to. At the same time, there are people who moderate their use. There are people who abstain from heroin use but still use alcohol on occasion, or abstain from alcohol use but still use cannabis or marijuana. And so I think one of the challenges for us is we don't know who is who when they come in to see us, right? Despite any intuition that we might have about this situation or assumptions we might make about a person's situation, we don't necessarily know. And so we really need to trust people to tell us and to experiment and to figure out what works for them. And so I think even setting up things like non-abstinence goals or non-substance related goals, those recovery capital goals, putting those things on a treatment plan are things that we can do in any treatment setting that I think embrace this idea of harm reduction and, individualized, strengths-based care that we can offer to people. And how this relates to the question about enabling, and I'll actually move from this, I think, one of the questions one of the things that we can do on administrative harm reduction, whether we're talking about hiring and onboarding or program materials, is the type of language that we use in our treatment programs, I think, is really significant. And so I'm glad that the person who asked this question brought up the idea of enabling, because enabling is definitely one of those things that I think comes up as a regular concern when we're talking about harm reduction, because, I was doing a consultation group one time, and the person I think was actually a nurse of some kind, and what she said, which really stuck with me, was, and we were actually talking about intimate partner violence in this situation, and she was talking about someone who she was working with who was in an abusive relationship, and she said, I feel like if I don't just tell her she should leave, that I'm essentially telling her she should stay, and that I'm doing harm to her. And so I think that conflict comes up for people when we're doing harm reduction, is that if we feel like we're not pushing someone in a certain direction, that we feel like we're continuing to enable their risky behavior. And at the end of the day, I think it's important for us to sort of take a step back and realize that people have the choices to make for themselves, and that if we aren't operating in sort of this more open and flexible way, who are we cutting out? And so just like we don't know who is the person who can moderate or who can only pursue abstinence, and that's the only thing that's going to work for them, I think when it comes to these financial considerations, like, we can just say it doesn't feel good to be lied to. It doesn't feel good to feel like somebody, said they were going to do one thing with a resource and then they did something else with it, and that's okay. It's okay to feel crummy or feel like, hey, I thought I had a better relationship with this person. Why aren't they telling me the full truth? And we should also depersonalize that, because when people lie to us, that's not always just a reflection of how we're engaging with them. I think it's also an indication of how people have been taught to behave and engage with the world around them to survive and to get their needs met. That probably that person thinks the only way of getting their needs met sometimes is to lie to people. And things like, helping someone get a bill paid, keeping a roof over their head, preventing them from engaging in more risky behaviors to acquire money that they might use to spend on drugs. All of that can feel very enabling. And I think it's important that when we talk about things like providing for people's basic necessities like housing, shelter, food, medical care, all of that might feel like enabling. Helping someone keep a job has been labeled as enabling at times. And I think it is a helpful reframe and a respectful alternative to think about that as supporting someone, right? That you are making a good faith attempt to support this person with a resource that you have. And if you withhold it because one person lied to you, then the next person who could benefit from that resource isn't going to get it, and not through any fault of their own. And so I think it's hard, but important to try to depersonalize and offer that service, I think, in a good faith way as best as possible. Hopefully that answers some of those questions. And then just here, a couple other things about language. I think many of these we're familiar with at this point: addict, junkie, alcoholic, crackhead, pothead. A lot of that I think has been sort of phased out for person-first language, a person who uses drugs, and even substance abuse being replaced with substance use disorder, reflecting the changes in the DSM. Dropping clean and dirty versus using a positive or negative drug test. Again, that I think also is reflected in language that came out of HIV services. Some of these I think are a little bit more challenging to us. So things like relapse, and there is evidence. Ashford is the researcher here. I believe I put his citation in the references, but relapse is shown to promote more stigmatized and negative attitudes towards people who use drugs. And so when possible, like when we're engaging with people, we might use language like recurrence of use or just use, like you used again, because relapse is a really loaded term. And similarly, saying that someone is in denial is a really loaded term when, in clinical terms, most of the time what is happening there is a person's in pre-contemplation. We have language for this as substance use treatment providers, and we should use it, right? You're just, as it relates to this particular behavior, you are not in a place where you are even considering whether or not this is a problem. You don't really think it is a problem, so you're not interested in considering any changes to it at this time. I talked about creating other frameworks, so not just an addiction to drugs or a disease, but a relationship with drugs is an alternative language option. And then even things like medication-assisted treatment have been shown, I think because of the history of the term, to promote stigmatizing attitudes. And so I know here in Illinois, we have shifted in all of our formal documentation to using the language medication-assisted recovery. So again, putting the word recovery, I think, in the term is helpful. Or even some of the research has said just pharmacotherapy, medications for substance use disorder or opioid use disorder are all more respectful and less stigmatizing alternatives. And so updating our program materials, and again, I think whether you're in a residential program or outpatient, making sure that our program materials have language that reflects this respect and less stigmatizing attitude towards people who use drugs. Those are all things that we can do to signal to people that we view them in a more positive and strengths-based light, and that we are kind of creating a different type of environment or setting than they may have encountered in the past. So we're now shifting into the second half of our training here. And so I'll bring up our next poll question. And so this one's a quick one. But I would say still a very significant and heavy question. So do you know someone who has experienced a drug overdose, either personally or professionally? And so I'll give you all just a quick few seconds to respond to this one. And like I was saying, we're now moving into kind of the overdose focused portion of our webinar. So I'll give you all about 5 or 10 more seconds to respond here. We can go ahead and close that one out now. So, among the people who responded, the vast majority of people do know someone who has experienced a drug overdose. Something like, let's see, it's about 6 to 1. So, over 80% of the people who responded to the poll do know someone who has experienced a drug overdose. And I mean, I think that's a really significant and important starting point for the conversation that we're going to have about incorporating overdose prevention into substance use treatment. That this idea that it is just extremely common, whether it's personally or professionally, that the people who are working in this field have exposure to people who are experiencing drug overdose. We know overdose is part of the work and the people we serve, but that doesn't mean we always discuss it directly with people. And, just like I was saying for administrators, there's a parallel process here, right? Direct discussion puts something on the table, and it is necessary and valuable. Just like administrators should be explicitly talking about how to incorporate harm reduction into their services, providers should be explicitly talking about overdose prevention with the people that they're serving. And so, it's not just about knowing this information, but then how do we communicate it to people and when do we communicate it with people? And I think that's where the harm reduction philosophy kind of comes into place, is it's not going to work to just try to threaten people and scare people. It's about understanding and being familiar with the person, helping them tell their own story, and interweaving, kind of building in this understanding of their own personal risk factors with the information that we have that might be helpful, right? Not about trying to shame someone into doing certain behaviors, but kind of instead giving them the information that they need to make safer, healthier choices. And these are just some of the benefits of, when we incorporate overdose prevention in substance use disorder treatment, some of the things we might see. So giving people space to process past trauma, increasing the likelihood that they'll survive future overdoses or avoid future overdoses, building and improving that therapeutic relationship. And again, I think a lot of overdose prevention and harm reduction comes down to this idea that what matters to me most is your health and safety, not whether or not you use, not whether or not you experienced an overdose. I want you to be safe, and that's why we talk about this overdose prevention stuff here, or I want the people in your life to be safe. And that's where I think this idea of affirming people's value as community members who can save lives is also important, right? You may not need this for yourself, but there are other people in your community who might still be using, who might be at risk. And I want you to be able to help them as well with this information or with this naloxone kit, for instance. And then enhancing the system capacity to address the traumas that occur. And then also I think this is more supportive and helpful for treatment providers. If we're saying 80% of the folks on this webinar today have some exposure to overdose, the more that we can cut down and reduce that, and the more often that overdose doesn't result in an overdose death, the better we are as a system to sort of prevent the worst consequences and the worst experiences that treatment providers might encounter in their work. So we're going to start looking a little bit more closely here at overdose. And I think just some basic factors to cover with overdose. And if you all want to chime in on the chat here with some of the things you know about overdose, I'm not going to go too in-depth into the basic overview of overdose, right? So you see the questions here. So what are some common factors that increase a person's risk of overdose? What are the common signs of an overdose? And, what steps should a person take to respond to an overdose? So you all can go ahead and sort of respond to those in the chat and share what you all know with each other already about how to recognize and respond to an overdose. And for those of you who are looking at this and thinking, gee, I really don't know about these things, there are some good training resources that are out there already. So you see here the FADA training module on overdose and naloxone basics, this FCB online webinar course on opioid overdose prevention, recognition and response training. So these are different resources that can kind of give you this basic foundation in overdose prevention. I think that's a really good starting place. So some increased risk factors that people are identifying, so depression, right? So mental health would be something that increases a person's risk of overdose. Whether they personally experienced a trauma or the death of a loved one, so some type of loss, a lack of social support. As a step to take to respond to an overdose, having access to Narcan or naloxone, and we'll talk more about that. And lack of knowledge of the drug being taken. So things are mixed with other drugs. Many drugs are synthetic, and we don't know what's in them. We're going to talk more about that. This person mentioned, returning to use after a long period of abstinence. So your body may not be able to handle the same amount. A reduced tolerance is an extremely important risk factor for someone's experiencing an overdose. Polysubstance use, also mixing drugs, and we'll touch on some of these as well. And then some of the signs of overdose that I've also seen here are people being unconscious or a lack of response. And so those would be maybe the signs that we would be looking for with an opioid overdose, right? Non-responsiveness, inadequate breathing. And I mentioned both here opioid overdose and stimulant overdose or overamping, because in a stimulant overdose, if someone's using meth, speed, cocaine, ecstasy, things like amphetamines and methamphetamines as well. Those are things that raise someone's heart rate and their blood pressure and their body temperature and speed up their breathing. So it's going to look very different than it would for an opioid overdose. And those things can actually lead to stroke or seizure or heart attack. And so, again, those are different things that you'd be looking for in terms of the signs of an overdose. And so, other people are saying, Narcan, CPR are important responses. And again, the responses those would be responses that are helpful for opioid overdose. So we'll talk a little bit more about those ideas as we go through this overdose prevention material. But I can see you all already have a basis in understanding things about overdose. And I think hopefully part of this will be about how do we help share that with the people who we're seeing in our programs. So here you can just see overdose deaths in general are on the rise. This is true across the country. And then, 2020 so far, the data that we have for it, it has just been a really terrible year in terms of drug overdose deaths. So you can see from, through the 12-month period ending in May 2020 compared to May 2019, there's been a 32% increase in the number of overdose deaths in Florida. And so I would say, this issue has been urgent for a long time, but especially so right now and in Florida. So I think so grateful that you all are part of this webinar today and that you're bringing this information back to your programs. Just generally here, you can see the trend line that Florida has followed over the past few years, and this actually mirrors trends that have occurred across the country, which is a steady increase over the last really 10 to 20 year period up until about 2018 when there was a slight decrease and then a return to a slight increase in 2019, and then so far in 2020 a pretty sharp increase. And that's pretty similar to what's happening everywhere in the country. Next here, just some quick details about, and this is specific to the drug type involved in overdose deaths in Florida. So opioids are the most involved in drug overdose deaths. So that black line on the top actually incorporates a few of the lines below it. So the brown one, synthetic opioids, that's fentanyl. The green is natural or semi-synthetic opioids like oxycodone and hydrocodone or morphine. So OxyContin, pills usually that people are taking. The blue line is heroin. So, and the purple line at the bottom there, that's methadone. So you can see really fentanyl is most responsible for the opioid overdose deaths. And as in other places in the country, fentanyl is really, most common everywhere and involved in close to 80% of opioids are involved in something like 80% of all overdose deaths, and fentanyl is the most common among those. And that's kind of the trend a lot of places right now. But then the other lines that you see here, so that pink line is cocaine, and that is actually the second most common drug behind fentanyl, individual drug. And then psychostimulant or meth and cocaine deaths are both increasing. So that gray line you see there, that is psychostimulant deaths on the rise. A couple other things that are sort of unique in Florida is that heroin is actually less common than it is in other parts of the country, whereas natural and semi-synthetic is more common. And meth involvement is actually less common in Florida, but cocaine involvement is more common, and that's just relative to other parts of the country. So this will bring us into our next poll, which is I kind of wanted to get a sense from you all, what is the most common drug of choice for individuals in your substance use disorder treatment program, excluding alcohol? So you see here the options are prescription opioids or pain relievers like oxycodone or OxyContin, heroin, fentanyl, cocaine, methamphetamine, or some other type of pill that people might be taking, like benzodiazepines or benzos. So I'll give you all a few seconds to sort of respond here. And while you're responding to this, I will just say, something else that I think stands out from the data that we have about drug overdose deaths, and this is true of Florida and other places, is polysubstance use is very common. And we don't totally know to what extent that is because people are intentionally mixing drugs or there is a contaminated drug supply and people are unintentionally taking things like fentanyl, which someone else mentioned as part of the risk factors. But, that is pretty common, is that multiple drugs are involved, and oftentimes opioids are sort of the most commonly involved. So here I'm curious, we can go ahead and close out the poll. So I'll be curious to see, when people are coming into your programs, other than alcohol, what is the drug that they're sort of saying is kind of their top drug of choice? And so a lot of folks being treated for prescription opioids and heroin and then fentanyl. So sort of in order. And so interestingly, someone said we didn't have THC on the list, but we see a lot of THC use. So besides the pain relievers. So yes, did not include cannabis or marijuana on this list, but I understand that might be pretty common. But I think what's interesting here is, what I'm seeing is a lot of people coming in for opioids in the response. So more than half of the people who responded have opioids in some form, whether it's prescription opioids, heroin, or fentanyl. And actually the largest group of all of the responses was prescription opioids, which I think speaks to kind of the disproportionate number of the higher rate of prescription opioid use in Florida relative to some of the other places in the country. But then you also see things like fentanyl. So prescription opioids and heroin are both higher on the list than fentanyl. And so it's interesting to me that even though fentanyl is the most commonly involved in overdoses, that actually it's a pretty small number of people who are actively seeking out fentanyl itself. And so I think that speaks to the fact that fentanyl oftentimes is finding its way into the drug supply in ways that people aren't prepared for or recognizing. And then we also see methamphetamine a little bit higher than cocaine relative to some of the folks. So it sort of makes me wonder, for the people who, because we saw on the last slide how common cocaine is, and I'll just throw that back up here for 1 second, but because we see cocaine as the most common, as the second most common behind fentanyl, but it's less commonly the drug that people are coming in with, it just makes me kind of curious about, to what extent we're either missing people who are using cocaine, or that people who are using cocaine are actually maybe primary opioid users who use cocaine sometimes, and that's where some of these cocaine deaths are coming from. So I think interesting to sort of think about, people who kind of might be using multiple substances. And someone actually just said in the chat that there are people using multiple substances, so it really is a toss-up where prescriptions, opioids, heroin, fentanyl, cocaine are kind of all in there together. And then they said, another person said most clients are polysubstance users. And so the last thing I'll just acknowledge, so a couple of people asking about THC on here, so specifically cannabis. And the reason I just didn't include it in this poll is because, cannabis doesn't show up in the drug overdose statistics. So I was sort of more curious to that element of it, substances that might be contributing to overdose. But I think we see here from the poll and from some of people's comments, it is a real mix of substances that you're seeing, and then also it's combinations of substances. And so I think really, again, important that we sort of emphasize that in what we talk to about people who are using substances. And so that brings us into overdose prevention strategies. And, as Floridians, probably you've been on a cruise before, or you know someone who has. And if you've ever been on a cruise, you know that one of the first things you do when you get on a cruise, other than take a picture next to a life preserver, is you get on the boat and you line up and you do a drill. And they show you where you will find your life vest, and they show you where you will find your life raft. And at the end of the day, you're really hoping that you have this information, but you never have to use it, right? And so I think in a similar way, when we talk about overdose prevention planning with people, this idea of sort of knowing where the life preservers are, it doesn't make it more likely that something will go wrong, but it makes it more likely that you'll know what to do if things go wrong. And again, like when it comes to working with people in substance use treatment, we know that overdose is a possibility for the people we're serving or for the people in their lives, and not talking about it doesn't make it any less likely that it's going to happen. So when we're talking to people about overdose prevention planning, broadly speaking, we want to be incorporating these three key components, right? Prevention of overdose, so understanding some of those overdose risk factors that were identified before, recognition of an overdose, and a response, so making a plan for what you would do if an overdose occurs. And with all of these pieces, I think it can be helpful to keep in mind the elicit, provide, elicit model, which we've talked about in some of the motivational interviewing trainings, which is before you go and start just giving a bunch of information to someone, to sort of ask what do they know already or what has their experience been, and then to use their information as your guidepost. So fill in the blanks as opposed to offer all of the information. People do not like being told things that they already know to be true. And then again, some of these risk factors were already called out by people, but these are some of the things that most significantly increase people's risk of overdose, which is a tolerance or, following a period of abstinence, people haven't been using as consistently, age and physical health conditions, how they use, the route of administration, injection more risky than snorting or smoking, for instance, but also knowing that smoking and snorting still carries an overdose risk, having a history of overdose, mixing drugs, so combining whether it's multiple types of opioids, pills and other pills and alcohol, opioids and cocaine, obviously being a common example based on the statistics there in Florida. So knowing kind of the risks associated with mixing drugs. Then how do you recognize an overdose? So knowing what those symptoms are. And then the response. So when you're talking to somebody, in general, you want either that person, if they're around someone who's overdosing or if they were overdosing, time is of the essence. So helping people have a plan in advance, make sure that they'll be able to act as fast as possible. So what would you want someone to do if you were overdosing? Or what will you do if someone you use with overdoses? Having those kind of conversations can be really challenging, and it might feel very foreign to the people who we're working with, but I think it's important that we start to explore those things with people. And here's just some examples of response options. So we've talked a little bit about, calling for 911 and administering naloxone, giving rescue breathing or chest compressions for opioid overdose. And for stimulant overdose, the real question really comes down to, does this person need rest or medical attention? And if it's just rest, it's things like hydrate, slow down, cool off. But, the things that might require medical attention are things like a stroke, a seizure, or heart attack. And then again, you'd be following first aid practices there based on their physical symptoms. So, things like if someone's experiencing a seizure, if you can, lie them down, place something soft underneath their head, those types of responses would all be really helpful there. And things that could go into people's plans. The next thing we'll be talking about are some other topics that you might want to discuss if you're engaging someone in overdose prevention planning. Here, some folks had mentioned polysubstance use as a risk factor. So when we're talking to people about polysubstance use, obviously we want them to know what are the riskiest combinations, so things like opioids with alcohol, cocaine, or benzodiazepines, sort of mixing those up, making sure people know what are the riskiest combinations. And some other strategies that we might build in with people, and these are all harm reduction strategies related to polysubstance use. Tasting, so start low and go slow. When you're using a substance, and this applies whether you're using multiple drugs or not, is use a small amount to start off with, right? If you're injecting, inject more slowly. If you're snorting, snort a smaller amount, a smaller line. Because you can always take more if you're not getting the effect that you were looking for. But once it's in you, it's hard to get it out. So start low and go slow, or tasting your drug to sort of get a sense of their potency. Use less of each drug or use one drug at a time. I think those kind of fall into the sort of the same category of, if you're mixing drugs, how come? Is it just because the other one's there, or is it because you really like the effect that you get from mixing them? Could you use less of one or another? Unpacking and exploring that with people, taking unknown substances first. So, for instance, if someone combines opioids and alcohol and they just say like, well, whenever I do it, that's how I do it, that's what I want to do, then, in that case, if they're going to mix drugs, it's better to take the unknown substance first. So, for instance, opioids, you do not know what the potency of an illicit opioid is going to be. You do not know if there's going to be fentanyl in it. Same thing with like pills that you acquire from the street. But alcohol that you buy from a store that has, a label, you know how potent and how strong and what the effects will be from alcohol. So it's better to take the thing that you don't know first, so that when if you add on to it, that you're adding with something that's more of a known entity. Letting a friend know what you've taken so that they are aware of the combination. And then last, contamination. I see someone just asked about fentanyl test strips. And so that brings us to this point about contamination very helpfully. So I think most of us know by now, fentanyl is a really potent synthetic opioid, and it has been used in clinical settings since the 1960s. And so I think it's important to distinguish here between sort of fentanyl that gets used in hospitals as a way to treat pain and also illicit fentanyl. And so fentanyl gets made in illicit ways and then mixed into the illicit drug supply. And it is increasingly present in the illicit drug supply as evidenced by our overdose data and toxicology reports and all of the information that we're getting. And I think an important detail to share with people about fentanyl is it does still respond to naloxone in the event of an overdose, but because it's a more potent opioid, you may need more. I think also important to know about fentanyl is skin contact alone with a powder does not cause an overdose. I think that's helpful more in general when we're talking about fentanyl. But I think, for people who may have heard news stories about like people just touching or coming into contact with fentanyl and experiencing symptoms, it's important for people to know you can't know if there's fentanyl in a powder just by touching it, or if there's fentanyl in a pill just by touching it. And so when you look at some of the examples of the images on here, on the left and on the right of the Xanax pill, that's what an actual Xanax pill looks like versus a Xanax pill that was confiscated on the street in San Francisco that had fentanyl in it. And the blue pills are M30s. They're stamped with M30s. They're made to look like prescription opioids, and they actually have fentanyl in them. So again, despite those kind of concerning stories from emergency responders developing symptoms after skin exposure to the powder or to the drug residue that has fentanyl in it, those symptoms that they experienced were not actually consistent with opioid overdose or opioid poisoning. That's just because the drugs just aren't absorbed well enough through the skin in their powder form. And so if you want more on that, there's the American College of Medical Toxicology. As far as fentanyl test strips go, they're a relatively new strategy, and I would say whether you're using fentanyl test strips or more advanced testing mechanisms, so like mass spectrometry testing is one of the things that are being used here in Chicago. There really are a lot of limitations, which is, if you shave off the wrong part of the pill, you may not detect fentanyl. Where I think fentanyl test strips can be really helpful is as an engagement tool. So if someone comes in because they hear you have fentanyl test strips or they hear you're testing their drugs, you can also give them a naloxone kit when they come to your program. And so I think that is helpful. And there is some evidence that people alter their behavior based on the presence of fentanyl. Some people will skip using a supply because it has fentanyl, or some people will just use in a more measured way because of fentanyl. And then also an important thing to keep in mind with fentanyl is something that can happen, especially when fentanyl is being injected, which is called wooden chest syndrome. And that's where basically a person's chest locks up because they're overdosing on fentanyl, and it becomes really hard to provide rescue breathing or chest compressions in that case. Again, still give naloxone, and calling for medical attention that's one of the reasons why medical attention is really helpful. So never using alone is an important overdose prevention strategy. And if you're using with someone else, obviously the biggest thing is that there's someone there to call for help. But if you're using with someone, it's also important to recognize that you can stagger your use with the person who you're with. That's one potential strategy. Again, that if a person's going to use, doesn't really cost them anything, but maybe a few minutes, and doesn't mean that they have to use different amounts necessarily or make any other major adjustments. Just why don't you use first or the other person uses first, and you can watch each other to make sure you're okay instead of using at the exact same time. And there are definitely a lot of significant barriers to using alone. I think the biggest one is still stigma, which is, people don't want someone to know that they're using, especially if they have pursued treatment and recovery. And that goes both ways. Both, the friends and family who are supportive of your recovery, you don't want them to know that you are going back to using. The people who you told you were going to stop, who you used to use with, you might be embarrassed to let them know that you are returning to using. And so that stigma is really complicated. The safety and trust, right? Not only to recognize that when you're using with someone, that's a very vulnerable position that you're in, but also that that's someone who isn't going to just run away, but actually be willing to help you out if something goes wrong. And then add to that, along with everything else, COVID-19, the guidelines there are isolate and be away from other people unless it's absolutely necessary. And so it makes it challenging for people to use with someone else there if they're also trying to isolate and protect themselves from COVID-19. So here's some alternatives to using alone. One is notifying a nearby family member or friend and getting on the phone with them. I know of folks who are using that strategy. But there are also some new call lines and smartphone apps that have been developed recently that I think are also good options to offer to people. To say, if you are going to use alone, you can call this phone number, the Never Use Alone hotline there, and someone will stay on the phone with you. And if you become unresponsive, they can call emergency services and tell them where you're at and that there is an unresponsive person at that location. The Be Safe Community Brave app, that also connects you to a person in a call center who can contact emergency services or a personal contact for you. The Canary app is a little different, no operator there, but the app itself actually detects movement. So if you stop breathing or if you stop moving altogether, it'll send alerts. If you don't respond to alerts, it'll set off alarms or call someone for help. So all of those provide different options that we can give people so that if they are going to use alone, at least there's some mechanism for getting help to them if they end up experiencing an overdose. We've talked a little bit about naloxone. I think the basics of naloxone, hopefully we're all familiar with, and if not, there are those other training resources I mentioned. But basically, naloxone reverses opioid overdoses. And at this point, any person who uses illicit drugs or prescription opioids should really be carrying naloxone and be trained on how to use it. And along with that, anybody who knows someone who might be at risk of an overdose should be carrying it. Florida has a great system for getting people connected to naloxone, so I'd really recommend connecting with isavefl.com. And also just acknowledging here that naloxone has its limitations, so you can't self-administer naloxone. It only works on opioids. It is dose dependent, so you need more if you're taking more potent opioids, and it's a shorter half-life than common opioids, so an overdose can recur. And I think that just sort of leads to, again, the importance of seeking out medical attention. This photo here, I'll just mention. So someone's asking about the smartphone apps. Those are going to be listed in the resources, and I'll put those in the chat in a minute. But we're running out of time, unfortunately, so I'm going to keep moving for now, but I will put those in at the end. This image here, though, is just from a public health campaign that we ran here in Illinois that really just tried to emphasize to people that, when we save people's lives with naloxone, that we are saving parents and children and siblings and family members, but also important community members and people who can and will do great things with their life because they were saved by naloxone. When it comes to medical attention, overdose is a complex and taxing health problem. It puts a real strain on your body. It can impact multiple organs and systems. It can be exacerbated by pre-existing conditions. An overdose can reoccur if naloxone wears off. So it's really best for people to be treated in a hospital setting. And so, we do want to encourage people to seek medical care. At the same time, we can acknowledge that there are lots of barriers to that. People have had their, bad experiences in healthcare systems. I know someone who I spoke to who signed a do not resuscitate because when he went for an overdose, they gave him such a large amount of naloxone, and it was extremely painful for him. People are afraid of legal repercussions. And so that's why I put the Good Samaritan law on here, which is, in general, there to try to protect people from criminal penalties for those who are experiencing an overdose or calling for help. And they encourage people to seek help during an overdose emergency. The evidence about them shows that the states that implement Good Samaritan laws have reduced overdose deaths, and it does not increase use itself. And then again, it can also be undermined by either limited protections or unnecessary requirements. So I've put on here your state's Good Samaritan law. I think the main things to know about it are the protection is from arrest, charge, or prosecution for possession of the substance or paraphernalia, but it only applies to the person who calls for help. They also can't be violated for pretrial release, probation, or parole. So for whatever reason, that protection does not extend to the person who overdosed unless they also called. So there's certainly limitations with Florida's Good Samaritan law, as there are with everyone's Good Samaritan law. But I think just those are the key details to sort of know about it. Some additional considerations when you're seeking medical attention, you can tell people like one option is to try to focus on the physical symptoms. So if you don't want to say the person overdosed, you can say this person is unresponsive, they've stopped breathing. Obviously, if we're calling from a treatment program, we're going to say exactly what happened because we want to give the operator as much information as possible. But when we're talking with people in our program, we might want to let them know about these options. We want to stay with the overdose victim as long as we can because overdose can reoccur. Discourage additional substance use. So if someone wakes up, we want to discourage them from taking additional drugs and try to orient them to the situation. If we have to leave someone unattended, we want to put them in the recovery position. We want to take if possible, if there's time, take any drugs and paraphernalia and just put them out of plain view. And if we don't feel comfortable, I think, just calling and staying until help arrives, either transporting an individual to a hospital ourselves or calling for help, leaving a door unlocked and waiting until help arrives and kind of leaving out the back. I've heard of people using that as a strategy. So all of those kind of provide different ways for people to engage people who might be reluctant to seek medical attention. So here, I'm actually going to move us past this poll since we are running out of time, unfortunately. I feel like I just jammed so much in here because I have so much I want to talk to you all about with this topic. But I think just an important consideration here is just to think about, what is it that your program is already doing related to naloxone? Are you currently providing naloxone to everyone who comes in, to people who you screen as being at risk, to nobody, or do you at least refer to some other program to give them naloxone? And so I really think there's a lot of different settings where naloxone distribution is appropriate. In Florida syringe service programs, it's actually required to provide naloxone or to offer naloxone. And then in substance use disorder treatment programs, and I have another resource I'll connect to here, just talks about all the different settings where you would want to incorporate naloxone distribution within a substance use treatment program. And you see here some of the other places where naloxone's occurring in Florida. So if you're interested in becoming a naloxone distribution site, you can contact the email there at the bottom, isavefl@myflfamilies.com, and get connected with DCF in Florida, which runs the Narcan program. People, especially people coming out of withdrawal management, people who are newly initiated to methadone or buprenorphine, people who are new in treatment, and just people in treatment in general are just all at risk of overdose. And so the best thing we can do is actually hand every single person in our programs a kit for naloxone or get them to some other resource that can link them with that. In Florida, you all have an opportunity to provide direct distribution, which is considered more effective than handing someone a prescription. And the formulation, you don't even have to choose because DCF specifically offers Narcan, although intramuscular is really common. And so if people carry intramuscular naloxone, I think it's just important to be aware of that and supportive of that as well. One example in Philadelphia, in their opioid treatment program, they actually developed partnerships where their pharmacies deliver naloxone to their OTPs to make sure that every patient has a kit. And just encouraging people to carry naloxone, and not only for themselves, but then if possible to have extra kits to give. So this is the idea of secondary distribution, but extra kits to give out within their social networks. Here are just some language suggestions. So this piece by Doe Simpkins and Bell is linked to in the study, and is linked to in the references, and it gives you a few options for how to talk to people about carrying naloxone. And so just one example I'll highlight from here, and the article goes into a few different situations and the types of language you'll use. But talking about naloxone and overdose prevention, you can say, this is practical information that everyone should have. Just like knowing how to do CPR or the Heimlich maneuver, everyone should know how to prevent and manage overdose. And again, destigmatizing, because I think people can be put off when we bring overdose prevention to a conversation. We want them to be able to say, like, hey, this isn't about you personally or my expectations of what's going to happen when you leave this program. This is about information that can help you and help the people in your community. And so that's why really it's important to offer overdose prevention at pretty much every step of the way in the process. How and when we're talking to people about overdose, there's just so many opportunities to incorporate this. And whether that's intake and assessment because we're screening for things like trauma related to overdose or past experiences related to overdose, or in an orientation, letting people know that if they resume use or if they experience an overdose, that they won't be judged or they won't be discharged. Obviously when people, like I mentioned, are being inducted into buprenorphine and methadone, really important to connect them with overdose there. In counseling, we can explore people's past experience of trauma. What did they do past experience of trauma related to overdose? What did they do to avoid overdose? What did they do to try to help someone who experienced an overdose? So you sort of see the opportunities for education around overdose really go throughout the process. And I think even just things like honoring special occasions or moments like International Overdose Awareness Day give people an opportunity to both grieve and also to talk about overdose in their lives. One other thing here, so I'll just acknowledge we are out of time, so I'm going to sort of move through these things quickly. But this resource, I just want to highlight a few things about it. So if you are working in a substance use treatment program, and again, this really goes out to the administrators who are listening to this webinar, you should build in ways in your program to help people cope, not only with overdose fatalities, but near misses, non-fatal overdoses can also be traumatic experiences, both for your fellow, for the people you're serving, but also for the staff at these programs. And so these are some of the things that, as a program working with people who are treating people and when an overdose occurs, these are some of the different strategies that an administrator can implement and promote. And these 5 core actions, I want to just highlight because these 5 core actions are really, shown to be helpful with people who have been exposed to a traumatic event that involves loss. So promoting safety, like attending to basic needs, promoting calm, which is really about listening and helping people develop coping tools or maybe normalizing their intense emotions, promoting connectedness, whether it's, with each other and with your fellow staff members or peers, but also with, encouraging people to reach out to family and friends for support. All of these are kind of key elements of what to do to help staff cope with overdose fatalities. And so important to think about how we can integrate these practices into our services as well. Last, I kind of just encourage you all to think about, what will happen with these conversations. It's hard talking to people about overdose, and whether it's because we're uncovering traumatic events or hearing people say things like, I don't know if I deserve to live, it's really heavy material that we're working with here. And while we may be reluctant to put these things on the table, I think that it's really important that we do because it shows people how much we care about their lives and keeping them healthy and safe. And that ultimately it can help contribute to building a therapeutic alliance with people. So where I will leave you with are these final thoughts, which is that drug use does not have to result in overdose, and a drug overdose does not have to result in death. Harm reduction makes that possible, and harm reduction can save lives. So thank you all for your time today and for being here. And I encourage you all to sort of sit with this material and hopefully find ways of bringing pieces into the work that you're doing already. If you do have more questions or thoughts about this material, please feel free to reach out to us, either at practiceforprogress.com or you can contact us by email as well. I'm going to just move through the slides here at the end so that the references make it into the recording of the webinar, and then in a moment I will add the apps that I was referring to earlier. So here are some resources in Florida, and again, the isavefl.com website. I would really encourage you all to go to get connected with naloxone resources for yourself and for the people in your programs. Here are, again, some of the references that I made, and if you're interested in some of the Florida-specific data, that's Ahmad up there. The Coping with Overdose Fatalities, the resource that I introduced there at the end, I think really important for administrators. And then for people who are interested in incorporating harm reduction psychotherapy, there's lots of great resources. I would recommend Denning and Little and some of the writing that they've done on the topic. I think their materials are really accessible. The Harm Reduction Coalition has a lot of really great resources in general. And then here's the Dose Simpkins and Bell article that talks about incorporating overdose prevention and response into substance use disorder treatment. So that I would really say is a key resource for anybody who's interested in bringing more overdose prevention work into their treatment program. And again, you can learn about International Overdose Awareness Day if you're not already kind of recognizing and acknowledging it in your programs at the website there, overdoseday.com. And the Never Use Alone, so that is one of the resources that I mentioned, the hotline and the website there. So I'll go ahead and start listing those out in the chat in just a second. And then I think this other article that I'll highlight down here, Starting Where the Client Is, Harm Reduction Guidelines for Clinical Social Work Practice, has some really useful thoughts in general for how to incorporate harm reduction into service delivery. And that's Jeannie Little and Sheila Vicaria there. So I'll go ahead and add some notes into the chat, and then I will pass things over to Karina to wrap things up for today. Thank you all so much for being here, for joining this conversation, for contributing to this work, and really for growing your practice and looking for new ways to support the people in your programs. I just so deeply admire and appreciate you all and the work that you do. And so thank you for that, and thank you for being here today.
Thank you, James. You've shared a wealth of information with all of us. We've gotten some really good feedback and comments from you and the audience. So again, we thank you for presenting for us today. If you're able to stay on for a couple minutes, I just need to go over some housekeeping items. When I conclude today's webinar, your browser will take you to an evaluation on FLADA's website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation, and you can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health prefix and number for the first time that you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address you used when you registered for the webinar through WebEx, and the same email that you set your profile up with. This helps us connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be Messenger at WebEx. Evaluation will close on Monday, February the 1st at midnight. We do not email statements of credit. Instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Again, if you're interested in getting information or getting the recording of materials, you can go to our website, Resource Center Training Library. And we would like to thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation. Thank you.